Everyone, welcome to today's webinar, Implementation, Applying the Sequential Intercept Model to Local Action and Planning. I'm Dr. Melissa Neal from the Gain Center, and we're excited about today's presentation. We don't often get a chance to follow up with sites and learn how they've made progress after a sequential intercept model mapping has been done. So this is what we're excited to do today. And before we begin the presentation, I would like to provide some administrative notes. First of all, the views, opinions, and content expressed in this presentation do necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Ask questions, which we encourage you to do so throughout the presentation. Please use the Q&A panel to the right of your slides to submit questions. We will be taking notes of the questions, and at the end of the presentation, our panelists will address as many questions as time permits. Material from today's webinar will be recorded and made available as soon as possible. We also have two supporting documents related to the content of this presentation available for immediate download at the conclusion of our webinar. One is a tip sheet on health and justice partnerships, and the other is a brief overview of the sequential intercept model. As you see, we have a full agenda for you today. So at this time, I will hand the webinar over to Dr. David Morset at SAMHSA Center for Mental Health Services to offer some opening remarks.
Hi, this is Dave Morset, SAMHSA. I just wanted to tell you about the Sequential Intercept Map. It was first envisioned as a strategic planning tool by Mark Munitz, Patty Griffin, along with Hank Stedman in the early 2000s. The workshop was developed through an NIH-funded project in the mid-2000s, and SAMHSA released a brochure of the model in 2005. In 2011, we adopted behavioral health rather than mental illness to include substance abuse, mental illness, and co-occurring disorders in the model. And then gently, with growing momentum and recognition that crises often become the point of entry, the zero intercept was added to the model. The sequential intercept is that it is focusing not on a system will do next, but on opportunities to intercept or stop individuals for deeper involvement in the justice system. The map itself is easy to understand and interpret and provides a visual representation so that different representatives, often having different missions, goals, and knowledge, can come to understand their own part in the process and plans to move forward. SAMHSA well over 100 sequential intercept mapping workshops in cities, counties, tribes, even whole states. The intercept map is considered so important that it's cited in federal legislation under the Cures Act. Today, speakers with a wealth of experience who participated in the sequential intercept map to bring community leaders together to develop strategies to reduce the number of people with behavioral health disorders in the justice system. So read their bios, which you'll see on the with the PowerPoints. Let me just introduce them. We have Sheriff Kevin Bond from Pettis County, Missouri. Carla Pete, the director of the Long Beach Department of Health and Human Services, and Dark, the chair of the Santa Fe Behavioral Health Alliance. And without delay, let's begin with Sheriff Bond.
Provided for Pettis County. Pettis, Missouri is located about halfway between Kansas City and Jefferson City, Missouri, and West Central Missouri. And we are a rural area. We the smallest location as far as population for this presentation today. So for those entities or those listeners that may be listening from small areas, I hope this has the opportunity to provide information that will assist you being able to bring together people in smaller communities. Pettis has a population in the 2010 census of 42,201, and we have 686 square miles. The largest area is Sedalia, which is the county seat. If you're not familiar with Missouri, which probably you're not, we are the home to the Missouri State Fairgrounds, and we are the northern gateway to the Lake of the Ozarks. And Sedalia is considered, or was, there was a research project that was done in the early 2000s that identified Sedalia as a micropolitan, which is a community that other areas from surrounding communities come to here for access to services. Certainly they buy their goods here, but they also are coming here for other types of services. So even though our population is under 50,000, the reality is as many people come to Sedalia to provide services. In addition to that, we also have about a attendance of 300,000 that come to the Missouri State Fair annually, and so that obviously is an important component for services that we provide. We also have 5 smaller communities that are located throughout the county. The Pettis County Jail, which I administer as Sheriff of Pettis County, has a capacity of 210 beds, and last year we had a total number of admissions of 3,473 with a daily population of 173, 57 of which are pretrial, and 23% are female. You may be familiar with the B-2 stealth bomber, which is housed at Whiteman Air Force Base, which is on the western border of Pettis County, and it may give you a little better indication of the location or the type of community that we have. It is a rural community, but we have a large number of airmen that live within the county as well as adjoining counties as well. And I'll talk just a little bit more about Whiteman Air Force Base's involvement in our Pettis County Mental Health Coalition as I continue. Started in 2012 with a issue that came up with our 96-hour involuntary committals, and prior to that, the state had provided contract services to us for immediate housing of any 96-hour involuntary commits that we have. But as the state began to privatize, the facility that we took those committals to no longer automatically took them, which created a bit of a problem for us to be able to find beds. It initiated or started initially through the emergency room. We have a local hospital with emergency room services, and that's where the problem began at, but shortly afterwards, the sheriff's office and the court system began experiencing problems with it as well. And so Probate Judge Paul Beard had gathered a group of interested people together to address that issue, and we were able to find a quick fix to be able to take care of the situation. But it worked very good for me to revitalize that in May 2015 after I had learned about a program called the Stepping Up Initiative. And hopefully many of you that are listening in today are familiar with the Stepping Up Initiative. If you're not, I encourage you to go to the website at stepuptogether.org. It is a cooperative effort between the National Association of Counties, the Justice Center for the Council of State Governments, and the American Psychiatric Association, and was funded through a Bureau of Justice Assistance grant. I initially learned that the year that I was president of the Missouri Sheriff's Association, and followed that, the rollout of which was in May of 2015. And I thought to be appropriate time because we were seeing more issues within the Pettis County Jail that needed to be addressed. And there's an initial webinar that was done in May of 2015, and shortly after that, on June 1st of 2015, we actually signed on to the Stepping Up initiative by the Pettis County Commission, signing a proclamation for that. Part of that program, actually, the program involves several different steps, bringing people together, people that are users of the system, people that are workers within the system, as well as practitioners, and then looking and trying to identify what the problem is in the community and then searching for answers. So one of the first things that's done is to identify highest users in the criminal justice and mental health services. And so there was a study that was done within the Pettis County Jail. We found that 14% of the people that were arrested and being processed through the jail met the criteria for mental health issues. In addition to that, 16% of long-term inmates had some type of mental health disorder that needed to be addressed, which meant that if you were arrested and had a mental illness, then you were more likely not to be able to bond out or be released from jail and were being held long-term. We found out that a very large percentage of those people that were coming back, or that were coming into the jail, were also coming back to the jail, as we were experiencing a 95% recidivism rate for these individuals. So that identified the problem that we definitely needed to take care of. And that took about 6 months to be able to do, and then we kind of came to a stopping point of not really knowing where to go further. I then found out about the SAMHSA Gaines Center grant for the sequential intercept mapping and applied for that, and we received that grant funding for a day-and-a-half workshop for experts to be able to come in to map out our systems within Pettis County. So it uses the Sequential Intercept Mapping Model that Mr. Morissette spoke about a few minutes ago, of where there is a picture here on your screen that you can be able to see. As said, it's a very easy to read and understandable program that you go through and identify those areas of services that you currently have in your operation, in your system, and to be able to try to map out intercepts where you can be able to make a difference and potentially divert people out of the system. So that intercept mapping, we were able to develop a list of those services that are available within Pettis County. Now, Pettis County has no residential mental health beds. We have no 24-hour mental health services, and so many times we were relegated to either the emergency room or the Pettis County Jail for housing people, and we could be able to try to find diversion for them. And so that was many of the things that we were working on, but we began working closely with our healthcare providers that were in Pettis County, as well as people who have been users of the system. We were very surprised to be able to find out that there was a huge amount of interest in users of the system or relatives, parents, loved ones of the system, or of people that were using the system that were concerned. And so we had a very good turnout of interested people. And as a matter of fact, when we actually had the SIM mapping, we really had to pare down the number of people to attend. We were limited to 40 people to attend, but we had close to 100 people that were actually interested in participating. So for a small community like Pettis County, we thought that that was very good. So we stay mapping out the resources that we had available. And then the second half day of the program, we started looking at priorities that we needed to do to be able to better address the issues that we were having in Pettis County. The slide that's up on now is a flow chart for the Pettis County Mental Mental Health Coalition that was developed as a result of the SIM mapping. And you'll notice that I am chairperson of that. We meet on a monthly basis to be able to discuss as well as that need to be accomplished. And it allows us to be able to get out of our own silos, to be able to realize that other people within our community are experiencing the same frustrations and the same issues as we are in dealing with people with mental illness. And so you also notice that below that on the left side is the Stepping Up initiative that we worked on. We were able to receive a second grant that allowed representatives from the Pettis County Mental Health Coalition to go to Washington, D.C. for a Stepping Up Summit. But then below, the SIM workshop developed into a series of areas that we felt needed to have extra assistance. And so those were divided out into better usage of our jail tracking services within the jail, developing a CIT council, which is a crisis intervention team training for law enforcement and other frontline workers, develop a boundary spanner position who would be able to track a person's progress as they move through and are diverted out of the criminal justice system, those that have mental illness, a criminal diversion program that actually would be similar to a court diversion program. However, because of our court system having several diversion programs already in place, the judges were not interested in doing a court diversion program, and so our probate judge actually instituted a criminal diversion program that starts before the person actually has charges filed against them. And then finally, to address those people with lived experiences with mental illness and relatives by revitalizing the local NAMI chapter that had gone dormant back in the late 1990s. So essentially, we began to crawl before we walked, and we've been very successful in those projects. We've expanded our CIT council to now include 5 counties rather than just Pettis County, and we had our initial training, first CIT council training in April of this year. We are planning on having another one in February next year that we already have planned for. I want to also make note of a community mental health liaison position that the state of Missouri provides. Our community mental health liaison actually covers 10 counties, and so she has limited involvement here in Pettis, but is very useful to be able to assist and bridge the gap between mental health providers and the court system and law enforcement. So that's worked very well. Our diversion program that I spoke about before, that Judge Paul Beard has initiated, has been running about 9 months now. So far, we've had limited success with that, but we do have people that are tracking through the system and have high hopes that that's going to be very useful. The spanner position, in October, we learned that we received grant funding for a position similar to this, and this goes back to the issue of us working together with our health and mental health providers in the community. So we have a person now that is grant funded that can be able to track people through the system and be able to provide assistance to the different organizations and groups that work with people with mental illness, as well as coming into the jail to provide assessment and provide services inside the facility as well. Pettis County has been reinstituted and is helping those families that are struggling with relatives and loved ones that have mental illness. And then we still are on target to be able to try to open a diversion center which would provide 24-hour access to mental health assistance here within Pettis County, so we do not have to travel about 75 miles outside of the county. So the SIM model helped us to be able to develop this track to move forward, and we've been very successful in Pettis County.
Good morning. My name is Kelly Copy. I'm the Director of Health and Human Services Department. I want to thank you for including me in this important conversation. First, I'd like to give you a little bit of background. The City of Long Beach has approximately 470,000 residents, and it's very diverse in its race, ethnicities, income, and sexual orientation. It's about 2 square miles and is located just at the southern tip of Los Angeles County. We're the 7th largest city in the county, in California, and the 2nd largest city in Los Angeles County. As California cities, our residents are concerned about the increasing presence of homeless individuals and others experiencing homelessness and mental illness and substance use in their communities. I came from the county in Utah about 4 years ago to become the director of the Health and Human Services Department in Long Beach. We offer public health violence prevention efforts, homeless services, and the Housing Authority. We do not operate mental health or substance use services, as these are resources that are held at the county level. I was in Salt Lake County. I was heavily engaged in mental health and substance use diversion programs, so I came to Long Beach with that knowledge and that interest. I knew what was possible. We started before we met the SIM model. We started with a small group of partners, realizing that through homelessness and others, that we were seeing a lot of people cycling through the jail system, that they were not getting the services that they needed. So we began with a small group. It was me, the police chief, the city prosecutor, and later Los Angeles County's Mental Health Department and Mental Health America. Sorry, I'm trying to go. So this was our first attempt. So the original design focused on interaction, where the police department originally contacted a person with a mental illness and then we would work to appropriately connect them to the services they needed. We began and shared this model with the Department of Mental Health and Mental Health America as key partners to help us work through the different mental health opportunities. We basically said, if a police officer connects with someone on the street, we would decide if they were, if it was a criminal or more quality of life, and then determine whether they would go to jail or whether they could go to a behavioral health urgent crisis center, otherwise known as the 2359 model for mental health services. And from that, we designed 2 different processes to work to connect people to service. At the time, the LA County District Attorney, Jackie Lacey, began bringing law enforcement partners together with the Department of Mental Health to discuss how the county would better service prisoners in the county jail, which is the largest mental health facility actually in the country, and begin to divert them when possible. This effort, she brought in the Gaines Center to LA County to conduct some training at the county level. We participated in that as the city, and then we realized we wanted it for ourselves, and so we figured out a way to get the Gaines Center to Long Beach. And we held a day-and-a-half training, and we brought together many more partners than we started with in the first. And so what is, in addition to the original group, we included the LA's Public Health Department, Probation, Office of Diversion, the District Attorney's Office, more community-based organizations, faith-based organizations, hospitals. There's a large veterans hospital in Long Beach, and they were included in that conversation. We basically moved from what was our original plan, which you saw, to the intercept model, which allowed us to reframe our original plan to talk about full continuum of opportunity and to identify what was available at each intercept, to identify gaps and determine key areas of focus. We learned that many of the resources we already had in place in Long Beach, we already had many resources in Long Beach and the more that was happening in LA County Jail and in the court system. So there was quite a bit already going on. We just didn't have them aligned, and we weren't thinking about them together. Locally, in Long Beach, we had Intercept 0 and Intercept 1 services, such as mental health evaluation teams, 60 hours of mental health training for police officers, quality life officers working with homeless individuals, and a robust coordinated entry system for homeless individuals led by the Health and Human Services Department. If a person is homeless in jail or court, they can be connected to the multi-service center for assessment and connection to services. The Long City Jail rarely holds someone for more than 96 hours. It is utilized to hold people for short stays or until arraignment. From arraignment, if a person is required to remain incarcerated, they're transferred to the LA County Jail. The Inter 2, 3, 4, and 5 programs are primarily at the county court level and provided sparingly to the city due to resource constraints. For instance, the linkage program is available in Long Beach courts, but is only available a couple of times per month. We have room for partnership across the intercepts, and there's a lot of energy for the work. Our goal is to divert people interacting with the criminal justice locally in the city of Long Beach so they did not become of the broader, part of the broader county criminal justice system. As there are many stories that once they were in the county system, they were much longer than necessary and came out with worse outcomes. We did hurdles. One, while Long Beach is the second largest city in the county, it still represents only 5% of the county's population. We're a fish in a very big LA County pond. LA is a county of 10 million people. In addition, all mental health and substance use services are funded through the county. They're planned there, all decisions made there, and to attempt to drive a more local focus has been an adventure. We also, in California, passed Prop 47 a couple of years ago, which essentially made all drug use, drug possession, and theft to $950 a misdemeanor. So we sort of lost our carrot and our stick to engage people into treatment because it's just easier for them to receive a citation and plead out. As access to data regarding mental health and substance use were not really collected, so we had anecdotal information regarding the treatment needs of those who are interacting with our law enforcement on the streets. Information, data, programming requires resources including human capital and funding. The city's been leaning their funding beyond basic police department operations. Requests for data and those sort of things are all seen as just as to add on to what's already happening. And then we have a lack of funding for treatment and housing. But we progress. So when I was approached to do this, I started thinking, well, we did we used the SIM model. We identified a lot of different areas, but we haven't brought everybody really back together again a lot is across all the different partners. But what the SIM model allowed us to do is to identify what the overall model would look like, and then the various partners have brought really interesting opportunities as we've been working through. And so I want to share some of those opportunities with you that have started because of the SIM conversations. First of all, the city prosecutor and our local workforce investment network received $1 million from the Department of Labor for the PATH program, which was youth ages 16 to 24 who commit a minor offense of choice. They can go to occupational training, life skills development, mentoring, job placement, or post-secondary education, or choose criminal prosecution. The government now works with local community organizations to provide volunteer and learning opportunities to juveniles who are interacting with the police. Upon completion of the program, their charge is cleared. The jail began to collect data at booking. So at the booking now, they ask whether a person has experienced mental illness or substance use, or if they're in treatment anywhere, so they can start to really reconnect with services and also to gather those data about the impacts. What was approximately about 20% of those coming into the jail have mental illness. We'll begin a pilot program starting in a couple of months. We're placing a mental health clinician in the jail for those who have been booked to assess and connect to treatment in the community. We began to begin the law enforcement assisted diversion program for substance use. There's a model for this in Seattle as well. We're partnering with LA County for that effort. We need the opening of a behavioral health urgent crisis center, otherwise known as the 2359 model, which allows for the police department, the fire department, well, I guess the firemen can't drop off yet, but we're hoping they will be able to drop off folks that they are interacting with on the streets that have mental illness. It also includes walk-up. From there, they'll be fully assessed and connected to other services. We're able to negotiate an administrative regulation for the city that supports data sharing across all the city departments. So police, fire, health and human services, homeless services, code enforcement, all are groups to begin to better understand where different parties or different individuals are interacting across the city and how we can best begin to coordinate and connect for them the different services. I learned that the city prosecutor will also be including court linkages across mental health and substance use treatment in his court. So they're going to align all cases where mental illness or substance use is an issue onto Thursdays, and then be able to have folks there to help with assessment and connection. And the city's innovation team has focused on public safety due to all of this interest. Gathered data on the highest utilizers of police services in the city over the past 5 years, identifying 850 individuals. These folks have had over 11 interactions with the criminal justice system in the last 5 years. They began conducting user case studies to understand the many issues. They found at least 50% of the highest utilizers of criminal justice are homeless. It's the population who generally needs housing, treatment, and employment opportunities more than others. The Home Services Division is very engaged in how to address these issues. In addition, the innovation team has led design thinking sessions, many additional innovative strategies, including the creation of a data mart to allow for improving data access and coordination among partners. A few things. One, the more partners we engage in conversation and share in the model, the more possibilities that show up. For instance, the things I just reviewed came from many partners because they've been engaged in the SIM conversations and we're paying attention to opportunities. Having a plan and seeing where the different funding and service fits helps bring people and sources to the table. Second, many things sound like a really great idea, and everyone agrees we're going to do this, and then the details come into play as each department or provider discusses process or other constraints. For instance, about 2 years ago, we started conversations about placing a mental health worker booking to allow for assessment and connection to service prior to booking if the person could be diverted. First Department Mental Health only operates Monday through Friday on weekdays, which is not when most people come into the jail. They were willing to pilot during those week hours and maybe a little bit afterwards to have assessments, but then we couldn't actually connect to service at that time, so it ended the conversation about connecting booking into diverting before being booked in. The police department was talking, they were also coming up with a number of safety and process issues in the booking areas about signatures, consent, things like that. And so, a lot of different details where everyone said, this is a great idea. We have a lot to figure out. But while it can be frustrating, it's also an incredible opportunity to learn from each other's business and to stand in their shoes. It helps us for future steps together. Now, we've redesigned the mental health providers so that they're going to be coming in during alternative hours, testing once people are through the booking process and then connecting to services when those services are open Monday through Friday. You may have things and let them speak for you in spaces where you may not be invited. And patience, and even more so, persistence are essential. It's constantly pushing on existing systems, getting yourself into conversations, and being ready for the ask when opportunities present. For instance, I was meeting with the LA County District Attorney at a luncheon that she came to speak at, and she asked me the one thing that Long Beach needed. I told her we needed behavioral health at the crisis center. She made sure that in every conversation in a large group that was discussing the topic that Long Beach was included. From there, we worked closely with local providers, the planning department, and community members to site the facility, host community meetings, and ultimately approved through the Planning Commission and City Council. It's been 3 years since we started talking about this, so that's the patience part. And then more years of patience and persistence in work to find a site, a provider, contracting, and we're looking forward to the opening in April. So this model really helped us get on the same page. It brought our teams together, and it allowed for people to continue to work in all different pieces of it and begin to align as we move forward. So thanks for your time today.
I'm Tom Stark from Santa Fe, the Santa Fe's Behavioral Health Alliance, and I'll talk to you today about how the sequential intercept mapping exercise that we were so fortunate to have SAMHSA come out and lead with us has made a big difference in our community's ability to address the challenge of people with both mental illness and substance use disorders who are prevalent in our criminal justice system. Our alliance started 4 years ago. One of the district court judges was very frustrated with the number of people with mental illness in her court who just kept coming back over and over again, and she asked several organizations to come together. One of the things that was key is because she actually made her courtroom available when it wasn't being used for trials or hearings to host meetings, and that actually was a key part in attracting people to participate. Our primary strategy over the last 4 years is just to build diversion opportunities into the criminal justice system and to strengthen the behavioral health treatment system to be able to support those individuals. We've organized from the very beginning into 3 project teams, and then we quarterly have a meeting in the district courtroom talking about progress. And one of the key things the Alliance provides is just a place for people to stand up and say the great things they've accomplished and to get credit for their innovations and for making a difference. It's like a community forum. One of the big progress improvements we've had is 2 years ago in May, SAMHSA came out, led a sequential intercept mapping workshop where we pulled all our agencies together, and it was an extremely positive experience that led to the plan we've been executing the last 2 years. Our county, we're big, we're rural, we're diverse. We have a population of 150,000. We have significant population with severe mental illness. We have a major drug addiction problem. We have a large jail. The actual capacity is 582, but we run about 500. But 2/3 of the people in that jail are taking psychotropic meds to control their mental illnesses. The statistic that impressed me the most is we run 50 to 100,000 needles exchanged each month in our community needle exchange program. And right now our big push has been getting Narcan in the hands of every first responder and as many relatives as we possibly can. So we face very significant behavioral health issues which then complicate into criminal justice issues in our county. When we are sequential intercept mapping, the left side column on this chart are criminal justice agencies that participated. The bottom one is the 911 system, the Regional Emergency Communications Center. And then the right-hand side is the treatment community, behavioral health community, and we brought these organizations together and began expanding the dialogue we created when we started 4 years ago. We were fortunate to have also our state's, it says BHI here, that's Behavioral Health Institute, and that's our state's mental hospital. And they came to the fore and also participated. So we had excellent participation, 80 people. We held the sequential intercept mapping workshop in the court in their jury selection room. And it really brought the community together. And the community came together to learn what each other were doing. This is the map we produced, and its value was to really orient everyone to their role in the bigger process, which was extremely important, and then also to scope and size of the system, because this is really what their clients, their offenders, the people they're supporting, they experience all of this in one way or another, and really wanted to help each part of the system see the big picture. And the sequential intercept map was extremely successful for that. We came out of the mapping process with 5 critical objectives, which we've been working on the last 2 years. One of them was just communication information exchange, whether it's HIPAA, it's 42 CFR Part 2, it's just been very difficult to get agencies to be able to sit down and do community case management, forensic case management for people who were involved in multiple courts, multiple behavioral health systems. And that's one objective. Recognized we need a crisis center where law enforcement can take an individual in a mental health crisis as opposed to taking them to jail, or even as opposed to taking them to the hospital emergency room. We need a reentry council to help people get back into the community. Transition out of county corrections is an extremely high-risk time for overdose, for rearrest, and for injury of many different kinds. We needed more housing, and we need more treatment services, both for mental illness and for substance use. Progress we've made the last 2 years, we've really strengthened working relationships, and I can't stress enough, just having people who are innovative and want to make improvements, have peers from many agencies that they can stand up in front of and talk about what they've accomplished is extremely motivating and empowering. It's been very successful for us. In 2016, we joined the Stepping Up initiative, which our county strongly supports. We also got involved in what's called the Decarceration Project, which is being done under the auspices of the Stepping Up initiative. We work with Cluster 3, which includes 10 or 12 counties. We do telethons each month, exchange information. We've got a number of very, very useful ideas from counties in Michigan and other places we've never talked to without this Decarceration Project. We implemented a mobile crisis response team. The team has served 600 individuals over the last 2 years. And what's really interesting is that team spends actually 75% of its time not responding to crises, but actually going back out into the field, finding people who had a crisis, and ensuring that they got connected to services so they get stabilized and they don't go into crisis again. We'd love to have a much more connected behavioral health system in our community, but we have a lot of opportunity in that direction, and the crisis team is helping us make up that gap. We also, the county passed a $2 million bond to build a crisis center, and then they passed a sales tax increase to provide $1.5 million funding each year for that crisis center so we could operate it. We're in the process right now of RFPs. We're hoping by the end of 2018 or early 19 to have that crisis center open. We implemented a jail reentry program. We hired 3 reentry specialists to work at the jail. Their primary job, they get people enrolled in Medicaid. We're a Medicaid expansion state, and work very hard because the number one thing people coming out of corrections want is to get into drug treatment or alcohol treatment, and we're working very hard to connect the people with the agencies. We also, and this was started actually a little bit before we did this sequential intercept mapping, we have a law enforcement assistance diversion program operating. We were the second in the nation after Seattle, and briefly, this is a program where law enforcement officers can find, when they find someone who they could arrest for drug paraphernalia, small quantity, a minor misdemeanor that's drug involved, can offer them the option of going and getting into treatment as opposed to being arrested and going to jail. We have about 135 people who've been referred to this program. We have about 90 who are still actively participating in the program, and we're very hopeful that this is a model for detangling individuals from the criminal justice system while they can stabilize and really get traction in treatment. So we're very excited about this. SAMHSA offered trauma-informed response training. We competed for that and didn't get selected. However, we turned around and sent some trainers to a training in Phoenix. They brought it back, and we've trained over 400 individuals in both treatment and criminal justice agencies in trauma-informed response. Highly, highly recommend this. We've also implemented a treatment guardianship program, which is under the auspices of one of our state laws. And I won't go into detail with that, but it helps people with mental illness get treatment and stay in treatment. And then finally, Smart 911 is a national initiative we joined to try to provide first responders more information. So we got a lot of value and a lot of action and a lot of focused, concentrated community attention on improvements as a result of participating in the Sequential Intercept Mapping. We have several things we still need to do, and I'm not going into these in detail, but just figuring out how to share information more effectively. We're reaching out to our state's health information exchange, trying to find a way to use that. We have a horrendous bench warrant problem. We have 14,000 outstanding bench warrants in our county, and we really need to find a way to resolve that, because the bench warrant or fear of having a bench warrant keeps people from getting the treatment they need. Obviously, shelter, housing, coordination of when people are released from detention is another key issue we're working on with the courts. Getting clients where they need to be. We're a big community, and it's hard for people to get to treatment. We need more treatment, both for addiction and mental health. We're trying to expand peer participation. We haven't really got that yet. And we don't really have a long-term solution for how to hold our whole community efforts together. We're looking at the concept of forensic integration consortium, but we need some way to formalize, institutionalize the cooperation we've been doing the last 4 years. And that summarizes what I've got to say. Thank you very much.
Thank you very much, Tom. Thank you again to all of you, Sheriff Bond, Kelly Colby, Tom Stark. We really appreciate your time and providing information around how the SIM has been leveraged in your communities. At this time, we are going to move into some Q&A, and I strongly encourage all of you listening in to submit questions via our portal. We'll be going through these questions. And so, yeah, I see a couple coming through, so let's get started. The first is, where did you secure funding for your reentry specialist positions? So for those of you who spoke about having that position, the jail reentry specialist, where did you see some funding?
I can answer that for Santa Fe. As we're a Medicaid expansion state, so pre to Medicaid expansion, we had indigent funds at the county level that the state distributed. When Medicaid expansion took a lot of the things that those indigent funds had been paying for, that left the county with a little bit of flexibility, and the county stepped up and sort of, with the state's support, redefined the use of those indigent funds that had been paying indigent medical expenses and repurposed them to be able to hire the specialists.
Okay. Our second question is around information sharing. So in many communities, not just for this participant, but across the nation, many communities struggle with information sharing and barriers, as Tom mentioned during his presentation. So let me get that question. Are there any suggestions or successes that you would like to share in terms of effective information sharing?
This is Sean. Would talk about it from the size or from the scope of a small community. We actually started within the jail by forwarding information out to our service providers, both healthcare and mental health, by sending them a daily sheet of those people that have been arrested and booked through the facility over the prior 24 hours. That allowed them to be able to track their clients, and because of HIPAA regulations, many times they're not able to exchange information, which I did notice there were some other questions in regards to that. And so we developed a system where if those people were identified that had been arrested, the notice was made to us to contact them back, and so we would obtain a HIPAA release form that would allow us to be able to start the process of communication.
This is Kelly Colopy. This is Long Beach. We have a number of different departments, and through that, we've not in the past been able to share information across the different departments, or it's easy not to share. And so we worked with our city attorney to develop an administrative regulation that basically says that all departments within the city can share data. Now, that doesn't necessarily mean, this doesn't mean the data. It doesn't, not things covered by 42 CFR. But what it does allow is for us to begin to identify who in the different systems. So we now have data coming from the police department, from our home services, through our homeless management information system, and our fire department, all understanding where there are, where folks are hitting all the different systems. So we're working to to develop an app or some sort of technology will allow the constant connection for all the partners who are engaged with our homeless management information system. All of those partners do already connect. And that includes our quality of life officers, which are the police department interacting with homeless individuals, and the mental evaluation teams. So the connections are coming, but that administrative regulation opened up a lot of opportunity for the ability to share.
Tom, anything else you'd like to add to this?
We're actually trying getting what the sheriff described, sending out a booking list each morning to behavioral health providers. We're still running into barriers, so we're very much in a learning mode on that particular question.
So I like this next question. Someone said our county just finished out a SIM. What was the most vital actions? What were the most vital actions you took next to keep energy and momentum going?
Sheriff Kevin Bond, I can be able to say that we took the action points that were developed at the end of the SIM mapping workshop and actually made subcommittees within our group and assigned people that were most appropriate for handling those things to be able to move forward. We also wanted to make sure that we kept meeting, and so we ensured that we were meeting on a monthly basis. And so, now we're 2 years past that and are still going strong here. And so that is good. Obviously, you want to make great advantage of the little gains that you make and share those across the entire spectrum of your stakeholders, which keeps that enthusiasm going.
I totally agree with what the sheriff said. The other thing that we did that I think made a big difference is we had some private conversations with several elected officials, letting them know what the results of the Sequential Intercept Map were and what the goals were. And I think that just reflected back on helping people be encouraged to stay with the meeting process and the objective process.
And I would agree. This is Kelly. The key for us was that the key leaders across the police department, the city prosecutor's office, and also in the county were taking strong stands for this. So throughout no one came to the table unwillingly. People came because they know that there's something to be worked on. And so it has allowed the conversations to continue to take place. We're having conversations and a strong stand. So whenever someone stands up in front of any group, they're speaking for all of us and the ability to move things forward, which has kept the energy going and allowed for a lot of the new sort of a culture shift of how this can work.
Okay. The next question is sort of going to be more specific about peer support. So this person asked, how has peer support specialists assisted in implementing diversion and navigation through the system. And what would help in terms of equipping peer specialists for this work and introducing them into the criminal justice setting?
This is Tom Stark. I'll take a shot at this. We've been struggling with the peer issue for almost the full 4 years. Peers as navigators, that count as organizations that use peers as traveling recovery coaches to get people from appointment to appointment. The challenge we have in New Mexico is our particular Medicaid program has no ability to pay peers except a very restricted number of organizations to provide this kind of support. So our major challenge has been finding a way to pay peers in your role for behavioral health services. So, and it's a question of finding funding through the regular system.
Have anything to add around the involvement of peer support specialists in this work?
Yeah, in my, we haven't engaged peer support specialists specific to SIM or the criminal justice system, but we do engage them in our system. So many of our outreach workers are peers and are engaging, and it's helped us connect. And so we have a model for that, but it's funded through through our continuum of care versus being funded through our Medicaid system, which also does not allow for the funding of peers at this time. There's been a lot of conversations about the funding at the state level for community outreach workers, sort of promotora type models. So it may open up at some point, but right now it's not a space that we've engaged in regarding reentry as much. There are some local providers who are engaging peers, but we haven't really pulled it all together yet.
Okay. So the next question is one that is being led to us not through the panel, but they are being, so when you're that's planning on doing SIM mapping, how do you recommend engaging with and bringing people of different agencies, specialties, and backgrounds together to participate in the mapping process and implementing the action plan created at the workshop? How do you recommend bringing those groups together?
This is Sheriff Bond. I would go back to highly encourage people to look at the Stepping Up initiative, which the goal of which is to reduce the number of people with mental illness in county jails. However, when you start that process, you quickly find out that people will come together, in some cases, to be able to protect their own turf, but then that's that silo effect that then when you get them together and start brainstorming, then the barriers begin to come down, and you start seeing the frustration across many different disciplines. And so once you start that process and the community starts learning about it, or the mental health and the health community, then that opened us up tremendously for people, and we had extremely good response from that. So again, I would highly encourage you to go to the Step Up Initiative website at stepuptogether.org. It has helps and programming tools to be able to assist you in that process.
Okay, thank you so much. Oh, go ahead.
Now, this is Tom from Santa Fe. I think what helped us get people to the table was actually the fact that we had the SIM workshop at the courthouse, that the court is a leader in our community, and all the other agencies have a lot of respect for the court. So hosting it and bringing it out of an organization that everybody was used to responding to was part of what was effective to get everybody to want to be at the table. I agree with the sheriff. Some of them may have just been there to protect themselves, but there are a lot of them who came because they had a burning desire to make improvements.
Great. So we have approached the end of our time. I do want to give everyone an opportunity. There is a file transfer that pops up. If you have a pop-up blocker, you may not see it, but for those of you who are able to, we are providing these two supporting documents. As I mentioned earlier, the first one is focusing more specifically on the health and criminal justice partnerships as part of this whole process. The second supporting document is a one or two pager on the Sequential Intercept Model, and it includes our newest intercept, Intercept 0. So just welcome you to download those, and we've come to the conclusion of this presentation. Thank you so much again to all of our panelists for their time and information. We do have contact information if you would like to reach out directly to our presenters. Their information is provided on the slide at this time. We will just leave that up for now and just end the call. And thank you very much for your time and participation in today's webinar. Goodbye.